Um, Hello, everybody in the room, and hello to everybody who's watching in different parts of the organisation or wherever they may be. Those of you who don't know me, I am Emma Vardy. I'm a consultant geriatrician. I'm also the clinical frailty lead at the Northern Care Alliance. And I have an honorary clinical chair with the University of Manchester with the Academic Health Science Network, and the deputy lead for the healthy ageing theme for the Greater Manchester ARC. I'm going to talk to you today about delirium from evidence-based practice and policy and back again. You'll see what I mean. Well, not declarations of interest in that they're conflicts, but just to show you some of the other things that I'm involved in that show you some of the expertise that I have gathered over the years and some of the other groups that I'm involved in. So I'm a board member for the European Delirium Association. I'm a co-author on, I'll be talking about this later, a new policy document for delirium, and co-lead for a new James Lind Alliance research priority setting partnership for delirium that's going on at the moment. And I'm also part of the UK Hospital at Home Society and a clinical advisor to the delirium programme that's been going on in Greater Manchester under the umbrella of Dementia United. So I'm going to talk to you about delirium definitions, something about the terminology, why using the term delirium is really important, some of the risks and outcomes, about detection and the role of quality improvement and some of the work that I've done, a bit about prevention because it is preventable, a bit about community care for delirium, and a bit about policy, and also a smattering of some new research. I was recently at a meeting in Hamburg on delirium, so I'm going to incorporate that. And you know what? I didn't think this would actually choke me up a bit, but it does. It's my dad. So he experienced a delirium over a year ago now. He has dementia. He's in a care home. His name is Paul. And I'm sharing that story because it became really personal for me. And so all of what I'm going to talk to you about today, you know, really, it just highlighted some of the issues. And well, I'll let you know how he's getting on towards the end. So terminology. Delirium is an acute confusional state that's precipitated by an underlying physical illness that is not due to another condition such as dementia. So people with dementia are more at risk of delirium, but the two are not the same. And some of the characteristic features, there is DSM-5 criteria that go into more detail, but fluctuation, it can come on over hours or days. And there was a consensus group, Arjen Sluiter from the Netherlands published a paper because different specialties use different terms. So the term encephalopathy might be used in more neurology circles, but this consensus paper brought together various international groups to make it clear that delirium describes a discrete clinical syndrome, and encephalopathy is the underlying neuropathological basis. The two things are different. And again, one of the things that's come out of the national policy is using the word delirium as opposed to acute confusional state or various other terms that get used. So what is it? I've described already, it's acute, it's fluctuating, it involves inattention, so not being able to concentrate or maintain attention, and something called disorganized thinking, so where the person might kind of jump from topic to topic. You can't really keep their sort of train of thought in conversation. There are two key types. One is the hyperactive type, which is more you can't miss it as much, or at least you might not call it delirium, but you will know that the person generally has it because they tend to be agitated, restless, they don't sleep at night, they might have hallucinations, which actually might not be immediately obvious until you assess a person's delirium and say, you know, are you seeing things that aren't really there? Are they distressing? Tell me about it, which don't come to light unless you specifically hone in on it. And they can be really frightening, you know, like spiders running across the floor or mice like running around the room. A hypoactive type is more easy to miss because the person can appear more withdrawn, drowsy, not eating or drinking as much, less mobile. The key point is in both these scenarios, think delirium. In fact, think delirium and anyone at risk of delirium, and you'll see later why I say that. It's really easy to make a case, I think, for improved delirium assessment and care. So these are a few statistics that have been collated by colleagues who work as part of the PRU in London. But it doubles the length of hospital stay. It increases the risk of somebody going into a care home after they are discharged from hospital. People die 1.5 to 5 times increased mortality. It contributes to risk of dementia. So every time somebody develops a delirium, they increase their risk each time. If a person has an existing dementia, in Alzheimer's disease, there's evidence showing it doubles the rate of progression of that dementia. There's 3 times increased risk of fall. So it's a really common association. So delirium should always be assessed for in that context. Up to sort of almost half people in hospital in this building sort of behind me. And it's really costly, not just the human cost, because it is really distressing to see somebody that you care for with delirium. It's difficult for staff to care for somebody with a florid delirium, but there's all the linked costs through prolonged hospital stay, social care, etc., etc. And it's not without consequence. So, confusion, people tend to talk about it as if it's innocuous, it doesn't particularly cause harm, but we wouldn't talk about angina in that way. We wouldn't talk about a heart attack in that way. This is something that causes brain injury. We don't fully understand the mechanisms of how that happens, but the goal for delirium should be, similarly to angina, the goal is preserving cardiac function. With delirium, it should be about preserving brain function. This is a simple, well evaluated test which has been developed by one of my colleagues, Alistair McCulloch, up in Scotland, called the 4AT. It is part of our Northern Care Alliance delirium guideline. It's part of national guidance that everybody 65 years and over who is admitted to hospital, who attends hospital, should have an assessment for delirium, and that should be part of a triple assessment. GIRFT have talked about the triple assessment, which is NEWS 2, 4AT and clinical frailty scale. And it's it's really easy to do. It doesn't require a great deal of training. But some of this is observational, alertness level, the AMT4, like recalling age, date of birth, etc., attention level, months of the year backwards, and whether there's a fluctuating course. You get a score for each of those, and even people who can't engage in the test can still get a score. And if you have a score of 4 or above, indicates probable delirium. And it's got high diagnostic accuracy in lots of different patient groups. So yeah, this is the triple assessment that I was talking about, which is what is recommended for assessment of older adults. And so I'm going to talk a little bit about my journey with quality improvement. So this is work that I did back in 2016, 2017 with one of the organisations, Halo, that some of you might remember. So a group of us I was working at Salford at the time, started a quality improvement project, and our aim was to ensure that we were doing the 4AT in up to 65% of admissions, 65 years and over, coming to Salford ED. And we looked at different aspects, including technology, the electronic record, the Allscripts that's available at Salford, improving training education, and also leadership. So this is, I was very fortunate in that there was some money from NHS Digital at the time through the Global Digital Exemplar Initiative to be able to develop the electronic patient record. It included the 4AT and enabled that to be coded and added to the health record, which was a really handy thing to be able to do. And this is our really nice SPC run chart. You don't see too many, but you can see that red line. As soon as the changes came into the electronic health record, the compliance with assessing with the 4AT really jumped up. But I would also say that that was accompanied by a lot of educational sessions with different staff groups. And unfortunately, I can't say that it has been maintained to the degree that we got up to. We were getting up to around 40%, which was, we didn't quite achieve our aim. And I know that some colleagues in other parts of the country, for example, Scotland, in Edinburgh, they're very strong around delirium assessment, but it's mandated in some settings, and that will improve your compliance up to 80-90%. But it shows what's possible. And the data that was collected and was collected as part of the health record, we were able to use and evaluate. So what we looked at was survival curves for, this is on the right, Edinburgh data, Lothian data, and on the left, or my right side, is Salford data. You can see that green line is 480 of 0, the red line is 480 of 4 or above, and you can see that the survival curves deviate, but you can also hopefully see that slight dotted line. That's people who didn't have a 480 done. So in that group are probably, well, will be people who had delirium who didn't have an assessment. And this, we also looked at the 480 score. So it's not meant to be, 480 is not meant to be used as a severity score, but I think this shows that it does have a role. So you can see on the right, Salford, this is 30-day inpatient mortality. And you can see as the 480 score goes up, mortality rate goes up. And I have personally found that really helpful to be able to to be able to explain to families, you know, the importance of delirium and how serious it is. So I know that in Salford, and this ties in with other international published data, that if your 480 score is like between 10 and 12, your risk of death in the next month is 1 in 5, 20% will not survive that episode. Now that's really high mortality. It's as high, I don't know what the current figures for sepsis are, but I'm told it's as high as sepsis. As sepsis care becomes better, maybe the mortality for delirium will actually overtake it. It's certainly worse than the outcome for myocardial infarction now, because care for myocardial infarction has improved. But that really encapsulates why it is so important and why I I'm so passionate about raising awareness of it. Now, this is a research study by another group looking at what happens if people don't recognise delirium. So they analysed almost 1,500 older emergency department patients, looking at, you know, who was sent home, what happened to them. What they found was it was prospective that the staff missed, sorry, they said nurses, but I'm sure it's staff, not like focusing in on any particular group. And actually what we found from work at the NCA at Salford was actually the nursing staff were most on board. Anyway, that's beside the point. Nurses missed 55%, and actually, sorry, no competition, ED doctors missed 50%. But of those discharged with missed delirium, there was a higher rate of those people dying at 1 week compared to if it wasn't missed. Don't understand fully why. Was that because, well, it must have changed their care, or they remained in hospital for a bit longer? So yeah, that's important. This is another analysis that we did using the data that had been collated at Salford. And this was looking at the News 2. So I was involved in, I input into the working group that was involved in updating the News 2. So new confusion got added, but my observation was that that was not, that was quite poorly implemented. It wasn't always assessed. It was a bit hit and miss. There was a bit of confusion over confusion. You know, when is it new? When it's still there? Is it new? Does it still get scored? We're not sure. So anyway, what we did was we analysed people who'd had 4AT scores and News 2 scores. And we had a time frame, so sort of people could within sort of 4 hours of each other either side. And what the graphs at the bottom show is, so these are total 4AT scores going up to 12. You can see that in the score of 12, you know, that's a good going, very good going severe delirium. That significant proportion of the light blue were considered alert, so they were not scored as having new confusion. So actually, the results from that was that it was specific when it was correctly used, but it was not sensitive enough to be consistently picking up delirium. I hope I've got that the right way around. Yeah, low sensitivity, high specificity. Now, this is another study from the Northern Care Alliance, also analysing data. Claire will have seen this paper because I picked up on it when I saw it on social media. So this is some of my acute medical colleagues. They published it this year. It was looking at 121 1,000 emergency admissions. The data when it included that time period of when we were doing in the heyday of doing the 480 better, but between 2014 and 2022. And what that showed was that patients with significant respiratory compromise or reduced mental alertness, so that new confusion, they were more likely to die. So that new confusion, like if you had to weight certain features, like was one of the biggest predictors of mortality. It's an excellent paper and it picks that out as a key area. I was disappointed there was not one mention of the word delirium in that whole paper. And again, it just emphasizes to me that we need to get our consistent terminology right so that we're sharing across disciplines and we're all sort of pulling in the same direction. So how does delirium present? Well, I've explained a few ways: more confused, hallucinations, but it can be, just off their food and drink, reduced mobility. For people who are assessed at home or ambulance teams being called out, it can be stuck in the chair. It can be mistaken for, and I've seen it mistaken for strokes, mistaken for end of life, depression, or just missed altogether. And what are the causes? Well, there's this really nice mnemonic, and I must talk about this at least once a day with the hospital at home team that I work with, and pinch me. And it goes through all the causes and includes a few little added extras. So P is pain, but it includes cardiac. And I don't often see it, but I have seen people present with myocardial infarction where one of the first signs has been confusion. And in fact, I saw that reviewing some case notes recently on the ward. So again, it's a good, what this is a good, it should kind of focus you into a structured assessment. And that's why it's so important to pick up. I for infection, but also intracerebral bleeds, nutrition, constipation, dehydration, medication, metabolic, so any metabolic disturbance like hyponatremia, hypocalcemia. Various medications are particular culprits, so like opiates, prednisolone. There's a few other things like nefapam, a painkiller I really am not keen on as a geriatrician because it can cause confusion and urinary retention. But I'm also including in that alcohol excess. Again, a recent case of a patient I went to see on the ward who the referral was, this person's newly confused, can you come and assess? And so I actually did some learning with the doctors on that ward, doing the 4AT, asked about alcohol, and there was a history of alcohol excess. So therefore that lady went on some vitamins, Fabrinex, to prevent her going on to potentially develop a Wernicke's encephalopathy. Also nicotine withdrawal. And then E encompasses like pretty much all those other things. So sleep deprivation, not easy to get to sleep in hospital. So like post-surgically, earplugs can be helpful. Sensory impairment, so problems with eyesight, hearing aids. The number of times that people do keep those aids at home because they're worried about losing them in hospital. Moving places, so move from one part of the hospital to another, particularly at night, can be really disorientating. And then a couple of other things. Putting a urinary catheter in has been found to increase your relative risk of developing a delirium. Not entirely sure of the mechanism, but similarly, urinary retention is a really important one not to miss. I saw a lady who was very agitated, being moved from acute medical unit to the ward, and actually what she had was a palpable bladder rupture umbilical. So the treatment was not lorazepam, it was a catheter and then management of her constipation, etc., etc. So pinch me. There's a link between delirium and falls. A group from America, Jim Rudolph and colleagues, established that link with a systematic review in hospital-based studies. I and colleagues with the GM-ARC, we did a systematic review looking for literature based in the community. Not as many studies, but a few, and the direction of the relationship is not entirely clear, but it is there nonetheless. And for me, flags that in somebody's presenting with a fall, whether that be in hospital or in the community, they should be assessed for a delirium. And equally, somebody with delirium, we need to be aware that they may be at increased risk of falls. So investigations include some blood tests to look for and establish the cause based on the list I showed you before. Urine dipstick should come with a health warning because the number of times I see in notes read out, this person's confused and they have a urinary tract infection. The number of times I've also seen it's not a urinary tract infection, it's hyponatremia, it's a hip fracture, it's an intracerebral hemorrhage. So if you trip up at that first stage thinking confusion equals urinary tract infection, you will, number one, miss the underlying cause. And number two, you might be giving them antibiotics, which are inappropriate. So the guidance would be that the person needs to have symptoms of a urinary tract infection. And I appreciate that sometimes the person might have a confusion related to that, but you should always look for the underlying cause and send a urine off to see whether there is an infection, and also look back at previous results, because the story of whenever they get a urine infection, they're confused, and you look back and there's nothing grown in any sample that's been sent. So it's just a bit of caution, and it kind of basically turns geriatricians into irate monsters because we see it so much, or don't, that's the point. Some of these other tests are basically dependent on the patient. So blood cultures, blood gases, chest x-ray if indicated, ECG if there may be a suspicion and you have to be alert that it could be a cardiac cause, and CT head only if there is focal neurology, new confusion after a head injury or fall, or persisting symptoms, and if the person is on anticoagulation, it's urgent. So should everybody with delirium have a CT scan? I'm not going to ask you for a show of hands, but this study gives us some answers. So this was the diagnostic yield of CT head scans for hospitalised medical patients with delirium. They excluded those who already had some of those red flags, like new neurology, head injury. And then basically they looked at, of those other scans, how many were positive and showed something like a bleed, really small numbers. And then of all those where there was a change detected, all of them went home with either outpatient follow-up or palliated. Now, you could make the case that in that small number, it's still a small number, and maybe the person would want to know, but it does beg the question, should, it's a risk benefit. And I guess what this highlights to me is it shouldn't be a blanket decision that everybody should have a scan, because it's going to be a really low pickup and it isn't going to change your management in any majority of cases. And actually, there's different ways of doing it, careful explanation to the patient, their family, we could do this, but it's not really going to change what we do. And I think the tide is turning a bit, because I know that there's, been fear about coroner's inquests and what, if you don't do a scan and you miss something, what will be the outcome? But it's about individualizing and personalizing the management for that patient. And the evidence is it's got a really low pickup rate. So treatment, identify, treat the underlying cause, review medications, sleep hygiene, reorientating people, verbal and non-verbal de-escalation techniques, and providing information. So medication, so the couple of groups of medications that are not infrequently used are benzodiazepines and antipsychotics, and actually the evidence base is really poor. So there was a systematic review looking at benzodiazepines. There was only one study, and that had to be halted early because of adverse events such as falls and drowsiness, etc. And the risk of antipsychotics and cerebrovascular events is not to be dismissed. It happened to a patient I was caring for where there was a contraindication to a benzodiazepine, gave them an antipsychotic. I mean, this person was like smashing the place up with an umbrella, which sounds innocuous, but, if you're at the receiving end, pretty damaging. But that person had a stroke the next day after antipsychotics. So, it does happen. And the evidence base is really poor. You shouldn't give antipsychotics to people with dementia with Lewy bodies or Parkinson's disease, because they can have significant adverse effects. So the message is use with caution. Ideally, pick the delirium up early, identify the cause, de-escalate, avoid use of medications. And this is in our Northern Care Alliance guideline, listing the medications if you have to use something, what to use, based on available evidence and guidance. So, and this is a really interesting study that I heard about in Hamburg. I took a photo of my own headphones because I didn't want to potentially get copyright issues from Sony. They're my best piece of kit, my best ever Christmas present. Anyway, what this study showed is pre-recorded music interventions in delirium, a systematic review and meta-analysis published just this year, 8 studies, huge, highly significant. I hope I'm interpreting these statistics right, but 50% like reduction in risk of delirium for something pretty straightforward and simple. So yeah, that's something that I mean we have used. We did have like MP3 players and headphones, I believe, that we were using for people with dementia across the NCA, and I don't really know what happened to them. And I believe they are used in certain circumstances. But to me, you know, isn't it better for the person to have some music they like as opposed to being injected with a sedative, you know, to treat their delirium? So delirium is preventable as well as treatable. So lots of those kind of causes can also, if you can prevent, you can influence and prevent them, you can prevent delirium. These are some of the studies that have shown that. I've like shown reference the study, the Australian study about for each incident delirium increased your risk of dementia significantly. There's this Gideon Kaplan as an Australian colleague looking and showing that actually there's some evidence for reduction of incident delirium for people cared for in the community as opposed to hospital. And also there was a hospital at home randomized controlled trial that I haven't included here, but by Sasha Shepherd, a Scottish study, again showing that incident delirium for people cared for with hospital at home compared to hospital, they had less incident delirium. So, and these are some other studies that you can look up should you be so interested. Where am I? Yeah, so I'm going to move on to a bit of Greater Manchester wide regional work. So started work on this probably, I think it was either 2017 or 2018, and we developed some delirium standards under the umbrella programme of work of Dementia United. And these were contributed to by people who had cared for people with delirium, as well as health and social care professionals. We've been collating data, haven't got a full year for 2024, but what we've been doing in Greater Manchester, raising awareness, I think you can see that the numbers detected have been going up. This is from looking at CCG data and coding. So, and it's not because we've got more people with delirium, it's because we're detecting it more. And I think I'd love to be in a position of, we know we're detecting all the delirium is, and now we're actively trying to prevent it and reduce those numbers. And interestingly, in Australia, if a patient develops a delirium in hospital, they are fined for that. So it's considered a safety issue and an adverse outcome. So we don't in this country, but that's interesting. So during the pandemic, we developed a Greater Manchester Community Delirium Toolkit because there was pressure on the hospital beds. We'd already started to work on this. We felt there was a call for, could we better manage some delirium at home? And we published that work in 2022. And it was a pilot study, so we were collecting very basic, like what was available data. We didn't want to burden teams, so it was small numbers. But basically, of people screened using the 4AT, about half had a delirium. Of people identified with delirium, the vast majority were able to avoid a hospital admission, 70%, and the majority had a cause identified. Interestingly, just under half had bloods taken, and that was a bit of a point of dispute when we were designing it, because I was very much at that time coming from a hospital-based setting and thought, oh, you always need bloods to look for the cause. And my community colleagues, well, sometimes based on knowledge of the patient and, you know, common things are common, maybe you don't. So actually what this showed was we met somewhere in between. Not everybody needed them, and some people did. And I'm just going to show you the outcome from what Stockport did. They went whole scale, like changes across the system. And their initial pathway was that for everybody with an acute confusion, they would automatically have been transported to hospital. After they implemented their pathway, they managed to keep, I think, can't quite read it, but I think it's 88% were safely kept at home, so did not even go to hospital for assessment. But the pathway, which has been co-designed, co-produced, includes, you know, any red flags, anybody who didn't urgently need a CT scan or need hospital treatment would go to hospital, but showed that it was safe and effective, and the feedback from patients and families was that they liked it. So this is just so I don't forget to say a lot of people have been involved in that work. We had some people, some colleagues from Singapore who, after a bit of an internet search, looked and found all the stuff we were doing in Manchester and came to visit us. I think it was was it earlier this year or last year? I can't remember, time flies. Anyway, they came over to see what we did, and actually it was a really nice opportunity to showcase all the work that we'd done. But also in this picture, Helen Pratt in the sort of white and black cardigan, who she no longer works with Dementia United, but was being really instrumental in this work. But there's other people who have been carers, relatives like Marion and Anne and John O'Doherty, who has frequently talked about his experience of a delirium and it being so frightening that he has prostate cancer and he would not want to go through surgery for it because he's so afraid that he would have a delirium again. So it's been, very high impact, and you shared that story. And there's a lot of films and resources on the Dementia United website that this group of people have contributed to, and we're still in touch with Singapore colleagues, which has been really nice. So these are some of the things that we did. So some of the teams noticed that there were increased rates of delirium in summer months, so the link to dehydration. So we developed a summer hydration campaign. We also developed, and these are freely available, and we have had the information sheet approved for use in the Northern Care Alliance. So there are information sheets available, they are somewhere on the intranet, but you can also get them through the Dementia United website, but translated into languages that cover like over 97% of the Manchester population, and they're filmed as well, so it's not just written material. Also coming from people and their families, we developed a carer's top tips, which is for anyone going into a hospital or in a care home. I keep meaning to drop one off to my dad's care home, but I never quite get around to it. I'll have to take one up with me this weekend. And what people have said is they find it very empowering what they can do. This is just another little kind of sideline. This is an app that's been developed, COCU, by the University of Manchester, Emma Stanmore and colleagues, about falls prevention. And they've developed an app called COCU Lite that it's can be used by people with dementia. And it also has a brain health game and includes things about to raise awareness of delirium risk. It's like a matching game. So a number of national institutions have incorporated delirium in their overall work. So the Royal College of Emergency Medicines had a national audit. NICE has delirium guidance. The National Audit of Dementia has delirium in it, and it will in the next round. Scotland have been a few steps ahead, but they've got sign guidance on delirium and getting it right first time. I mentioned the triple assessment that's recommended, which includes the 480 for delirium. So then I've been really proud to be part of, this is a national policy developed by the Dementia PRU in London, led by my friend and colleague Liz Sampson, who's an old age psychiatrist. I'm one of the co-authors along with various other colleagues, but this is just a really important piece of work for the UK and for delirium. So it's called Delirium Matters, and what they did was they looked at all policy and that has been developed that would have anything related to delirium. They also looked at, they came up to Greater Manchester and brainstormed around all the work that we'd done and collated a list of priorities. Just going to mention this on the right. So the WHO has a document around optimising brain health. Delirium isn't mentioned in it, but I think hopefully you might appreciate from some of the things I've talked about that actually I think delirium and delirium prevention should be part of brain health because of the increased dementia risk. So these are the recommendations from Delirium Matters. It's about collating data, adopting consistent terminology, decreasing avoidable harms secondary to delirium, so very relevant in hospital, decreasing delirium after surgery because that's a common precipitating factor, and ensuring that care close to home is commissioned to support and supportive people with delirium. So we're in a really good position at the NCA, particularly the Oldham team who I work with, and I've also worked with the Salford team, and I'm sure other teams, I think there's colleagues work with the Bury team and Rochdale team. But Salford was one of the teams that was involved in the original pilot. So I'm just going to hone in into what's in this document. So in the decreasing avoidable harms, what they talk about with each of these areas is where data might be collated for, what initial priorities might be. So the rationale and the desired outcome is around reducing falls, hospital-associated deconditioning. What could drive this change? Well, Martha's Law, and actually Leeds Hospital has like a campaign called "My Mum's Not Right, My Dad's Not Quite Right," to raise awareness amongst relatives, to be able to highlight it to staff. The NC Pod has been suggested that delirium would be a focus area, so watch this space. And hospital reporting systems. And we do now have 480 on our frailty data BI dashboard. We've only got data for Salford because we don't have a joined up electronic health record at the Bury Rochdale Oldham sites, which is a gap, but it doesn't mean that we should be doing something to improve delirium assessment and care. And unfortunately, we have lost a bit of ground at Salford. We're currently just trying to make sure that that data is correct and all the right documents have been included, but it's looking like it's around 5% at the moment, which is really disappointing that we've lost so much ground. But it's been done and it could be done again. And what it's also taught me is quality improvement methodology, and what you do in one place is not always applicable to the other. So really like looking for bright ideas as to how we can, without an electronic health record that may be some way off, we need to do something in the meantime because it's still a really prevalent condition. And how would we evidence change? Well, start with routine patient safety data. So actually, Becky Williamson, one of the falls nurses, has been looking at data, and it is included datix around dementia and delirium, and found increased falls in the context of delirium, particularly on the Oldham site. So the next steps for this piece of work are, I've talked about most of them, but including, I'm going to highlight a James Lynn priority setting partnerships. That's an NIHR initiative. They've done it for various conditions, but they're currently going through a process of identifying a top 10 research priorities, which will hopefully help prioritise certain research and attract funding as well, because it doesn't get as much funding as various other conditions. So these are the QR codes for anybody who wants to look at the full Delirium Matters report, but you wouldn't have a lot of trouble if you did an internet search, putting relevant terms in. This is the James Lind Alliance Priority Setting Partnership. Please complete it. I think we've got around 150 responses, and not that we're competitive, but Australia, apparently other places around the world can also do JLA exercises. So Australia did a delirium one, and they're just finishing and analysing the results. And not that we're competitive, but we want to beat them. In terms of numbers, not numbers per population, because clearly it's quite different to ours. So yeah, it's a really unique opportunity for patients, carers and professionals to influence research priorities. So in summary, and hopefully, yeah, I'm about on time, delirium is really common and under-recognised. There is a high mortality, and it is similar to sepsis, but it just does not have parity, the attention that it receives. It's really costly. It's very distressing for patients and their families. It can be cared for at home using a bespoke pathway after excluding red flags. Prevention is really important, and there's an impact on brain health. Research outcomes are now translating into policy, and actually I think the stage we're at in the Northern Care Alliance, we need to get that policy back into practice. So I think that is my last slide. Yeah, the acknowledgement list just gets bigger and bigger the number of years that I've been working in this area. So I think I've got most people from across the world and around the country. But yeah, Helen Pratt was really key in terms of the Greater Manchester work. And that's my dad, who made it to the Christmas of that year, and he's still around this Christmas, and it has choked me up again. So yeah, any questions, I'm happy to be contacted, particularly if you want to get involved and start improving delirium detection in our organisation. Thank you very much.